Hello and welcome to this video press conference to announce and describe the results of a study of the cost effectiveness of MDMA-assisted psychotherapy for post-traumatic stress disorder. My name is Betty Aldworth, and I am the Interim Communications Director for the Multidisciplinary Association for Psychedelic Studies. I would like to take a moment, and I'll repeat this again later, to note that the safety and efficacy of MDMA-assisted psychotherapy is currently under investigation. It has not yet been approved by the FDA, it doesn't work for everyone, and it may carry risks even in therapeutic settings. To learn more, you can visit mdmaptsd.org. We'll begin today with the MAPS Executive Director and Founder, Rick Dowlin. Rick?
Thank you, Betty, and thank you all for listening. I'm just going to talk just for a minute or so. What I want to just give is a bit of the historical context of what's been happening. Basically, MDMA was, under the code name Adam, was a therapy drug from the middle 70s to the 80s. It escaped from those settings and became used as ecstasy, and then it was criminalized in 85. I started MAPS in 86, which was 34 years ago. So it took us from 86 to 92 to get permission from the FDA for the first phase 1 safety study. That's took us through much of the 90s, and then in 1999-2000, we started working on MDMA for PTSD. We did 16 years of phase 2 studies. So it took us 30 years from 86 to the end of 2016 to have our end of phase 2 meeting with FDA. We have since moved into phase 3 studies, and we've finished the first of 2 phase 3 studies. We'll get the results from that in the next couple weeks. And so things are, we had the interim analysis that was in March of this year. It was very promising. So what we're thinking ahead is, if we do succeed with the phase 3 studies and get MDMA as a medicine for PTSD, how do we get it covered? How is it going to be covered by insurance? And so the key to that is the cost effectiveness study that's being released today on PLOS ONE that Elliot will tell you more about. And so we have started with the phase 2 studies with chronic treatment-resistant PTSD, and on average severe. The phase 3 studies are also chronic, and the first one was severe. The one we're doing now is going to be moderate to severe. And unlike many other PTSD studies, we include people that have prior attempts at suicide. We feel that we really have to work on the hardest cases because of the stigma that's been associated with psychedelics, and also because those are the people that need it the most. And so we feel that if we can demonstrate that MDMA-assisted psychotherapy can work with the hardest cases, that will make it easier to be approved, and then it may be something that we can also work with people that aren't such difficult cases, and maybe it'll be just one session for them will help. But that's the big picture, and I think Berra can now share you some of the scientific aspects of our data and how it works.
Thank you, Rick. Now we'll turn to Dr. Berra Yazar-Klosinski. Berra is the Deputy Director and Head of Research Development and Regulatory Affairs for MAPS Public Benefit Corporation, a wholly owned group doing the actual, conducting the clinical trials and drug development as a public benefit corporation, which will return proceeds to the Multidisciplinary Association for Psychedelic Studies for further research. Berra?
Hi, I wanted to share a little bit about what makes the results from these research studies so interesting. So in our phase 2 studies, we had a combined group of patients that numbered around 105. And we compared psychotherapy with MDMA to at an active dose to psychotherapy with either placebo or a low dose of MDMA. And from the cumulative analysis of those studies that were published last year, we found that there was an 82% treatment response rate. We haven't done a head-to-head comparison with available PTSD medications, which include Paxil and Zoloft. However, from a historical standpoint, we compared the data from our studies to approved PTSD medications, and on this basis, FDA determined that that MDMA-assisted psychotherapy should be a breakthrough designated treatment. The important point that I want to bring home is that the effect of our treatment is large in comparison to psychotherapy alone. And what this means for patients is that they can have a dramatic transformation in their lives. And although it doesn't work for everybody, the people that it does work for are much improved. And the durability of these results from our phase 2 studies was demonstrated in a pooled analysis that was just recently published as well. And we had about 11 people out of 91 who had relapsed. So with that low of a relapse rate, we're really encouraged and excited about the phase 3 clinical trial results that are going to be available soon. And what we find is that with either 2 or 3 sessions with MDMA administered under direct observation with trained clinicians, that these results are possible for some folks. And we think that from our analyses and our projections that these results will be robust. And that's particularly why the cost and patient access of this treatment is so critical, because once you know that there's a proof of principle and something that could work, it's really important to simultaneously conduct cost effectiveness studies like the one that we're speaking about today. And I'll just wrap it there, because I think that the key take home message here is that there's a possibility that we're going to get to market, and it's really important to ensure that patients can access this treatment.
Thank you, Berra. We'll now turn to Dr. Elliot Marseille. Elliot is the lead author on the study and has a great deal of history in health economics. Elliot, can you share with us some more information about the study itself?
Yes, I'd be happy to. So we addressed this research question: is MDMA-assisted psychotherapy a good use of healthcare dollars to treat patients with treatment-resistant and severe PTSD? And our results indicate that it is not only cost-effective, that is to say, it's not only good value for the money, but that it will actually save the healthcare system money while providing very substantial clinical benefits. We used standard decision analysis techniques, standard cost-effectiveness analysis techniques to portray the costs and benefits of MDMA-assisted psychotherapy for the 105 patients that were served in MAPS's 6 phase 2 trials. From the perspective of a healthcare payer, like think of the Veterans Administration or the perspective of private insurance companies, over 30 years, if this therapy were provided to 1,000 patients, it would save roughly $103 million in healthcare costs and generate 5,500 quality-adjusted life years. A quality-adjusted life year is a standard measure of health benefit that takes into account both improvements in well-being and reductions in mortality. And the latter is particularly important because we know that people who are suffering from severe PTSD die at much higher rates, both from suicidality, but also because they're more prone to life-shortening chronic diseases, such as diabetes, heart disease, etc. So over 30 years, we found these very large savings, but even over short time horizons, the intervention is highly favorable. So MDMA-assisted psychotherapy breaks even on cost at 3.1 years. That is to say, if you assume that the benefits of the therapy abruptly stopped at 3.1 years, there would be no net cost, and it would still deliver about 900 quality-adjusted life years. But I want to emphasize that this is probably way too pessimistic, since we have research that suggests that that this therapy extends benefits, and actually that benefits increase somewhat out to 4 years. So the point here is that even if you look at short time horizons and make very pessimistic assumptions about the durability of the benefits, the intervention looks likely to be highly cost effective, if not cost savings. And these results are extremely robust. And what I mean by robust is that you could take far less favorable inputs to the model than the ones that we used, and understand that the ones that we use are the ones that we feel are best supported by empirical evidence. But you could take far less favorable model inputs and you'd still see very favorable cost effectiveness. Let me say a little bit of detail about how we costed the intervention itself. We used microcosting techniques, which is simply to say that we inventoried each of the resources needed to deliver the therapy and assigned a unit cost to that therapy and added it up. So it's a kind of simple accounting, like what does it take to deliver the therapy? But then we also wanted to account for, and I referenced this earlier, the difference in medical care costs for those who got the therapy versus those who didn't. And we looked at all-cause medical costs. We feel that this was an important decision. That is to say, we wanted to reflect all the possible reasons for medical care utilization, not just psychiatric ones, because as I mentioned earlier, PTSD is implicated in a wide variety of medical conditions. And then on the effectiveness side, we looked at the changes in people's health state. So we assign a utility value where 0 is the utility associated with death and 1 is perfect health. And in the case of MDMA, in the case of PTSD, it ranges from 0.37 up to 0.97, depending on the severity of case. So we take into account changes in people's well-being in that way, and also reductions in mortality to account for the total benefit of the intervention. So what does this mean for policy? As Berra mentioned, we expect to see MDMA-assisted psychotherapy become a legal prescription medicine in 24 to 36 months. And we think that this study will help payers to think about having MDMA-assisted therapy as a covered benefit, that they can begin to think about the implications of this for frankly, their bottom line, as well as their commitment to patient care. And so we're very encouraged that this will begin to move the conversation in the right direction of people having access to this important new therapy.
Thank you very much, Elliot. If there are any other comments that any of you would like to make, you may do so now. And otherwise, I have some questions that have come in. If observers would like to pose any questions, you can do so by clicking the Q&A button. I will reiterate that, again, please note that the safety and efficacy of MDMA-assisted psychotherapy is currently under investigation. It has not yet been approved by the FDA, the Food and Drug Administration. It does not work for everyone, and it may carry risks even in therapeutic settings. To learn more, you can visit mdmaptsd.org. A couple of other notes this morning. For those of you who received an email containing a link to our media kit, you'll find a corrected press release in there in just a few minutes. We have a few minor edits to the initial release. And you can also find more information about MDMA and various media assets there for your publication. If you would like to request an interview with any of today's speakers, you can do so at maps.org/media request. Thank you. Our first question is, What will it really take to get insurance companies to cover this sort of treatment, or perhaps the VA or Medicare? Elliot, would you like to answer that for us?
Yeah, I'll start, and Berra and Rick can chime in. I think the simple answer is we don't know. This is new. There is some stigma attached to psychedelics. There may be some resistance. On the other hand, results are results, and I've got to believe that ultimately the medical care payers want to do what's right for their patients, and is consistent with their bottom line, which this seems to be. So it may take some time, it may take some advocacy, it may take some repeated presentation of these results, and we will be updating them as we get more information and as the phase 3 trials are completed. So I think, you know, there's reason to believe that the case will become more compelling over time. So I don't think this is going to be an overnight, you know, change. And I think it's time to start the process now of introducing the idea of this therapy as a covered benefit.
I can add to that. So,
Rick or Berra?
Yeah, so we anticipate starting to engage with insurance companies and payers in 2021. And you know, this publication will be part of our portfolio that we'll present on. So that's why it's particularly impactful. And at that point, we also hope that we'll have some initial data from our phase 3 trials to supplement and build out on the story. I think that one of the points I'd like to emphasize is that unlike perhaps other companies, we're trying to get the whole treatment package covered and not just the cost of the drug, because we've, based on our data and other publications, we feel that it's really critical that MDMA is administered in the context of supportive therapy. And we think that this is an integral component to the results that we have received and expect to receive. So it's very important for patients to be able to access the complete treatment package, and that will be the basis of our presentations for payers.
Thank you, Berra. This anticipates another question. How much will the treatment cost once it's approved? Berra, would you like to speak to that, or Elliot?
I think that this is an open question. I can probably take it, but nobody knows exactly what the answer is. So there's likely going to be a range of costs for the complete treatment package that I was talking about. And we're still assessing how many sessions are important for the treatment results to be delivered. So this is an open area of investigation, and our phase 3 clinical trials are based off of 3 sessions, whereas the phase 2 results that were described and costed out in the publication are based on 2 sessions. So we've gone back and forth and are continuing to explore the variables around how many sessions, which also integrally influences the cost of the complete treatment package. So in addition, with the wholly owned subsidiary setup of MAPS Public Benefit Corporation, it's also important to keep funding the nonprofit MAPS, so that patient advocacy and critical social issues can be addressed. And maybe I'll leave that part to Rick to elaborate on a little.
Yeah. So MAPS, the nonprofit, is the 100% owner of the Public Benefit Corp, which is the for-profit. And the reason we needed to create that is because we do want to sell the MDMA at a profit to supplement philanthropy. In the history of MAPS, we've raised over $100 million in donations. But one of the things that's been very helpful to us to speak to donors is to say that there are so many therapeutic uses of MDMA. We're starting with PTSD, but there's a whole host of other conditions, and that we could continually go back to philanthropists to support this, but at the same time, we do have this opportunity to make money from selling MDMA. So we've created the Public Benefit Corporation, where we maximize public benefit, not profits. While we do want to slowly move into sustainability, ideally, from the sale of MDMA, depending, of course, on how many therapists we train, how many patients they treat, what the drug is, whether there's insurance coverage. The goal is not to price it the way a normal pharma company would price things, but to really maximize public benefit. And so we have been successful with philanthropy, and we think that we will most likely continue to be successful with philanthropy. So we don't think that we're going to, at least initially, completely replace all of our income from the sale of MDMA. So all of this is going to come into our decisions about where to price the MDMA. But the main thing to say is that the price of MDMA is a small fraction of the cost of the treatment. The treatment is really therapy. It's therapy facilitated by MDMA. And so different therapists in different parts of the country will charge different amounts. And we're not going to have a standardized cost that we require everybody to charge. And we're also thinking that there will eventually be thousands of psychedelic clinics. Therapists will be cross-trained with MDMA, ketamine, which is now S-ketamine is approved for depression. Psilocybin is coming down the road eventually as well. And so we think that clinics in different places will charge different prices, and we're just going to try to be very reasonable about the price of the MDMA.
I'd like to add one more thing, a point of comparison. Sertraline, which is an approved PTSD medication, actually costs the healthcare system $9,000 for within 1 year for a course of medication only. And in comparison, prolonged exposure, which is a common evidence-based PTSD psychotherapy, costs around $7,000 in a year. And there isn't the cost information available to look at what's the longevity of that treatment. If you get a course of treatment in a year, what happens next year and the year after that and the year after that? And based on kind of clinical practice guidelines that exist, we understand that continued treatment is often required for PTSD because the symptoms return when the treatment is discontinued for most available PTSD treatments that are out there already. And we especially feel it's important to look at the durability of results on the 3 to 5 year time frame that Elliot was mentioning for these reasons, because we only have one course of treatment that we're then ending and then measuring the impact years later.
I'd also like to note that this winter, MAPS will launch a formal and funded commitment to health equity, a holistic plan creating more pathways to access MDMA-assisted psychotherapy for historically marginalized populations. This program will include funding therapist and supervisor training, patient access, and ongoing community building. So addressing affordability through our own nonprofit philanthropic action. Elliot, you had mentioned earlier that, and Berra, you referred to updating the information in this study as phase 3 information is made available and more data does become available. Can you share what the differences might be in terms of sample size or the types of information we could expect in a follow-up study?
Berra, do you want to take that?
Yeah, I'll take that. So in our phase 3 clinical trials, we've taken great pains to include measures that we think will be important for health economics analyses and cost effectiveness analyses. We took a more structured approach to ensure that all of our new generation clinical trial protocols include the same measures. And what this will enable us to do is have large pooled data sets that will give us more power to be able to explore these issues around health economics and cost effectiveness. So we've used measures that were developed by the World Health Organization, as well as kind of the gold standard of quality of life measures looking at a variety of factors that can influence the quality of life of a patient. And furthermore, we've included a secondary endpoint in our phase 3 design that looks at functional impairment that's associated with having a PTSD diagnosis, as well as some labor market information. So if we're able to demonstrate using, ideally, if everything goes well, which is not a guarantee, if the phase 3 trial is able to demonstrate that we can have an impact on workplace absenteeism and presenteeism, for example, or if we could demonstrate that not only is PTSD-related functional impairment resolved or changed, and that this comes along with the economic data set that then supports it, I think that would be an especially powerful story. And that standardization of approach across multiple clinical trials is really what we intend to leverage to bring home that complete story around how to maximize patient access. Elliot, you have anything to add?
Yeah. You know, Berra, you mentioned productivity and absenteeism. This is not something we included in this analysis. So were it to be included, the benefits would be greater. In other words, we've underestimated the full societal benefits because we did not take into account the fact that people will be able to return to work as their symptoms recede and be able to work more productively, that is to say, less absenteeism. So just to underline what you said there, Berra, documenting that, quantifying that, and including that in the next round of analyses could be a very important enhancement to the economic analysis.
I would like to add that having a PTSD diagnosis often comes along with a whole host of other diagnoses. So there's greater risk of type 2 diabetes, there's greater risk of acute myocardial infarction or heart attacks, and our hypothesis essentially is that after the PTSD is successfully treated, not only will the benefits will be observed on mental health treatments and less reliance on mental health treatments, but potentially there could be an impact on physiological health issues that may not actualize in the absence of the PTSD symptoms being chronic and of high severity.
You're on mute, Betty.
Zoom. Are there further comments from any panelists at this time? Well then, I will thank everyone for joining us today, and please do be in touch again. That's maps.org/media request to submit a request for an interview. We will look forward to seeing you at the next virtual press conference and appreciate you taking the time. Thank you.
Thanks.